9800.
Talk 1470 WWNN Pompano Beach, Boca Raton, Miami, Fort Lauderdale.
Hi, this is Michael Blum. Join me on Mondays from 9 to 11 p.m. on WNN for The Michael Blum Show, where we talk about the things you don't want to talk about. We talk about sex, substance abuse, spirituality, and politics. Think, speak, and be heard. Join us on The Michael Blum Show.
If you believe you can or you believe you can't, you're right. What do you believe? Who is the only person who can stop you? Only you. When was the last time you have someone holding your vision, your dreams for you? When was the last time someone held you accountable for achieving them? That's when Lorena Anderson steps in and becomes your coach, your personal energy coach. With her powerful and proven techniques, she will assist you in assessing and accelerating your maximum potential. One of the most powerful tools is quieting your mind and relaxing your body. It allows you to de-stress and calm and eventually brings your happy back. If finding your happy is important to you, please call the Energy Shifter, Lorena Anderson, at 954-647-5525 to schedule a free half-hour phone session, or email her at lorenaanderson@gmail.com. She's looking forward to connecting with you. Call her. The opinions expressed on the following sponsored program are strictly those of the host, guests, and callers, and not necessarily those of this station, its staff, management, or sponsors. Amp2.tv presents You and Your Doctor, teaching you to live a longer and healthier life. Proudly sponsored by All County Healthcare, where people are the heart of our business. All County Healthcare is a Medicare certified agency where one call will service all your home care health needs. For more information, call 954-717-7027 or visit our website, allcountyhealthcare.com. Now, let's get informed to living a longer and healthier life. Here is your host for today's show.
Hi, welcome to tonight's show. I'm Lorena Anderson, your life and energy coach, and I'm thrilled to be able to bring to you tonight two more of our doctors. One for the first half hour, the second one for the second half hour. The first one that you're going to meet is Dr. Shapiro. But before we go into that, I would like to say thank you very much for All County Healthcare for sponsoring tonight's show, for sponsoring all the shows, You and Your Doctor. And also, it's being presented by Amp2 TV. You can watch us live on amp2.tv and go to You and Your Doctor. You'll be able to see us live on that. Or you can go to allcountyhealthcare.com and be able to see us live there as well. So, without any further ado, I would love to introduce our first doctor, Dr. Shapiro.
Hello.
Hello. Get a little closer to the mic. There we go. And it's a pleasure to have you. Welcome.
Thank you.
Our show here is all about educating and providing more knowledge for the ability of being able to make the proper choices when it comes to their health care. So your information that you're going to provide for us tonight is of utmost value. But tell us a little bit about it. First of all, Dr. Shapiro, where can they find you?
We have two locations, one in Boca Raton, which is 1401 Northwest 9th Avenue, and one in Boynton Beach, Florida, right across from Bethesda Hospital, 2828 South Seacrest.
And your telephone number?
Best way telephone is 561-734-5080. I'm actually part of a group. I am the sports medicine doctor, and we have, can I name the others?
Yes,
Yeah.
sure.
So I'm the senior partner. I do sports medicine. Dr. Luskin is a hand surgeon. Dr. Grandick is a joint surgeon. Dr. Wang, a joint surgeon. And Dr. Hepler is a spine surgeon.
Boy, you've covered the entire body by that.
We try to do that, yeah.
Good for you. That sounds wonderful.
Only thing we don't have is a pediatric surgeon.
Okay. So this is for mainly our population, our demographics on the show is from, say, 65 and up. But, you know, I've got to tell you, there are many, many people that are out there that are 65 and over that you'd never guess. You'd have no clue that they were that old. And that's not that old. I mean, that's not what I mean, but...
It's very interesting. I trained I did my residency in New York and my fellowship in Boston. And everybody there in a sports medicine fellowship, if you saw anybody over 35, that was considered old. So I've actually written papers and talk a lot to the population, the active population over 50. And I do a lot of rotator cuff repairs, and I tell people when I go to the conferences, a 75-year-old here is like a 95-year-old up north. So the whole point is, I sort of create a 75-year-old here is like a 35 to 50-year-old up north because they're so active. I see people who are playing tennis in their 90s or playing golf. I have one patient who's 101 and he continues to play golf. He's amazing. So you really have to. It's sort of the older population sports medicine, and it's really important because to them, if they can't play golf, if they can't walk, if they can't play tennis, if they can't play pickleball, they can't do the things they want to do, and then they will get old.
Yes.
So I really stress each person has a different injury, but each injury, can determine what the person can or cannot do. So the major thing is we're going to go into it, but each person's different. You have to identify the problem in each person. It's not cookie cutter. You have to make sure that you make the right diagnosis and the right treatment for that individual, not just, well, you're 65, this is your problem, and, and go ahead with it.
I love to hear that. That's fabulous. And just so you know, we want to hear your questions. We want you to participate in being able to have the type of answers that are most beneficial to you. So you are more than welcome to call in 888-565-1470. 888-565-1470. Call us. Bring your questions on. The doctor would love to answer them.
What I'd like to do is just sort of do for...
Just pull it to you. There you go.
I'm not used to talking to this thing. So basically, when somebody comes in, the two things that I do are knee and shoulder. So let's just take a typical patient, 70-year-old woman who likes to walk and play an occasional tennis.
Okay.
She has knee pain. Okay, so the first thing you do is if you go to a doctor, it doesn't have to be me, but if he doesn't get it, the major thing is listening to the patient.
Yes.
You need a history. You have to find out what she would like to do, what caused the pain, how did it start, what exacerbates her pain, what does she try to do for the pain.
Yeah, and how long she's had it.
Correct.
Because I mean, I've had a little glitch in my joint here, but I've had it for like 3 years now.
And it probably hurts when you try to open a jar.
You're right.
You have basal joint problems.
Oh, you have basal joint problems. Oh, my God. Will I live, doctor? I'm teasing.
You will definitely live. But again, a lot of times, the first thing, I listen to the patient. They tell me if they had an injury. A lot of people don't have an injury. It just starts hurting. So you have to listen what makes it worse, what makes it better, what they've tried to do. Then I do a good physical exam. Again, if your doctor doesn't touch you, which unfortunately is the way that a lot of doctors are doing it now, which really
without touch, how can
without
they diagnose without touching the patient?
Well, it gets them to see more patients that day. So that really gets to me. When I'm somebody that sees my own patient, I don't have my PAC, which is a physician assistant. I examine everybody. I do everything because I'm OCD and have to make sure the patient's better.
That's amazing.
So if your doctor doesn't touch you, there's a problem. Okay, so he needs to do a good history.
Yes.
X-rays of that body part. So get, ready for the X-rays. It doesn't hurt or anything, but you would want to see it. You want to make sure if it's arthritis or no arthritis or an injury if you've fallen. But then a really good physical exam. And then from that, sometimes you can just make the diagnosis then. Sometimes you need the aid of an MRI or some other process. But the major thing is history, physical exam, diagnostics such as X-ray or MRI, and then you make a treatment plan for the patient.
Gotcha.
In my patients over 50, with a little bit of arthritis and a torn meniscus, I try to keep them out of surgery.
Oh, good. Oh, I love to hear that. And you're a surgeon.
I'm a surgeon.
God bless you.
I've done over 6,000 surgeries, but I am the most conservative surgeon.
6,000?
And probably because I've had 5 knee operations myself.
Oh, so you know the rehabilitation, the pain that goes along with that, how long you're going to be down, shall we say. And
if you can avoid it, you avoid surgery. But, again, that has to be part of your treatment plan depending on your specific problem. So if you're 65, you've got a knee problem, I get the X-rays, you have a little arthritis, you probably have a torn meniscus with it, I give you a cortisone shot. If it makes you better, you never see me again. If it doesn't make you better, I get an MRI, we look at it and decide what's going to be the best. whether physical therapy or arthroscopic surgery, which is going in through tiny little incisions. You see what's inside and you trim the meniscus and touch up the arthritis.
Gotcha.
But again, if you can avoid it, you do.
Yes. Well, something, what's so amazing as well is that there's so much of our population now that do not feel their age. So say you've got somebody who's 60 years old, that's kind of like the new 40. Nobody stops living their lifestyle at age 60 or 65 unless there's something really serious that ends up happening.
My dad, who was an All-American athlete in college, is now going to be 89 in August. He still plays pickleball, and he still plays tennis. He still plays golf. I've given him some cortisone shots, never had to operate on him. My
Wow.
mother, I operated on her knee because she tore her meniscus, and it made her better.
Wow.
So the youngest person I operated on for their knee was 7. The oldest, which I hate to say, but I will tell you the little story. My partner says, I'm sending you an elderly woman. Fine. So I see a woman, and I look, and it says 98 years old. So I walk into the room, and I said, is your mother in the bathroom? And she says to me, she says, my mother's been dead for 50 years.
Oh, my God.
So
You're
I said,
kidding.
you're 98? She says, yeah. And she says, my old previous partner who's retired sent me to you because he said you're going to operate on my knee. I said, ma'am, you're 98 years old. We don't really do elective operations on 98-year-olds. And she says, look, she says, I used to walk 2 miles a day up to 6 months ago. Then I used a cane. Then I used a walker. Now I'm in a wheelchair. So I looked at physical exam. I looked at her x-ray. She had no arthritis. Cortisone didn't help her. Got an MRI. She had no arthritis but a torn meniscus. I operated on her. She was walking in 2 days. So if
my
she
God.
had done
In
poorly,
2 days?
if she had done poorly, I would have been the GOAT. But the fact that she did well, so that's not the norm, but that just shows that you have to look at the individual and not at it. I mean, you don't make your
Absolutely.
living operating on 98-year-olds,
No.
but for her, it was great.
Yeah, because she held her age so well. And not only that, but the physical exercise that she had been doing up to that point. And that's what I see with a lot of the elderly is that they don't stop their lifestyle. And their physical health and well-being are of utmost.
It is tied into that. I do a lot of shoulder. I saw a 91-year-old retired cardiologist. He had 25% ejection fraction, which is heart. So you would never operate on that person. But his pain was so bad in his shoulder, and he had a torn rotator cuff. And I said to him, look, again, doctor to doctor and doctor to patient. You're 91. You shouldn't have your shoulder operated on, even though you have a tear. He says, look, I can't sleep at night. I can't do the things. It's making me worse.
Yeah.
Anything you need to do, I'll sign off, even if I die on the table. I said, look, I'm an orthopedic surgeon. I don't deal with this stuff. But we did the surgery, and because of it, he was able to sleep. He went back to golf. It actually made his heart function better because he could be active, as you discussed, because he wasn't depressed. He was able to do the activities that he wanted to do.
I've got to tell you, if you have quality of life, you have quantity of life.
I agree.
And there's nothing more beneficial than watching somebody come back to life, especially when in a wheelchair. And then all of a sudden, 98 years old, there she is, 2 days later, walking and feeling alive again and full of...
Well, the story with her, too, she came back at 101 and asked me to do her shoulder replacement.
101?
And asked me to do a shoulder replacement on her. And I just said,
my God.
I got away with doing your knee at 98, but shoulder replacement's a much bigger operation. I'll give you cortisone shots. We'll try other things. I didn't have the guts to do the shoulder replacement at 101.
Yeah.
So.
Ooh, that's,
But she did very well.
She did. And she's, how many years ago was that?
I did her, so last time I saw her, she was 101. I haven't seen her in a couple of years, so, she would probably be 103, but she looked good, so she's probably still around, but just hasn't come in.
Okay.
So I'd like to talk about another thing. So the major thing, so with knees, I try to be conservative.
Yeah.
If you're under 50 and have a torn meniscus, 99.9% of the time, I'm going to recommend surgery. But over 50, I try to keep you out of surgery.
Gotcha.
Okay?
Is that because of the healing time that it takes, or
No,
their
If
rehabilitation?
I see somebody 22 and has a torn meniscus, I want to try to repair it because the meniscus helps prevent arthritis.
Oh, okay.
So if you're 75 and you don't have pain, me going in there, the only reason I'd go in to clean it up is for the pain. Once you're torn, the die is sort of cast if you're going to get arthritis. So the younger person I want to repair so they don't get arthritis. The older person, I'm only doing it for symptoms. So it's different.
Gotcha.
So as conservative as I am with knee, aggressive I am with shoulder, meaning that if you tear your rotator cuff, okay, and I describe it as this, if you can see this. Here's your shoulder, here's the ball, there's the socket. The rotator cuff is like a tenderloin steak. It's a big hunk of meat that attaches to bone by a tendon. That will never heal itself if it completely tears off.
Right.
And in fact, if you have a little tear, it's here. In 6 months, it's going to be here. In a year, it's going to be here.
Yeah, it's not going to get any better.
And I describe it as you have a rope with a ball, and you cut the rope. It's never going back unless you reattach it.
Right.
But the problem is with the knee, if your knee hurts, but it gets better, you can always operate 5 years down the road.
Gotcha.
With a rotator cuff, it retracts, the muscle atrophies. And imagine a long sleeve shirt pulled up, you pull it back. If you wait too long, it's like trying to bring a short sleeve shirt down to your wrist. It's non-repairable.
Oh, geez.
So as conservative as I am with knee, I'm aggressive on a active, healthy person. I tell them it's going to be worse in the short run because, you need an operation, you need the therapy, but I'm not looking for 2 weeks down the road. I'm looking for 4 months down the road, 6 months down the road, 15 years down the road, so you'll be able to do the things you want.
Right. Excellent. I'd just like to say thank you very much to our sponsor, All County Healthcare, for bringing Dr. Shapiro here with us to help educate us, because I don't know about you, but I'm learning a lot more about not only rotator cuff, but about the knees as well. And I used to be a fitness trainer. I know it's going to sound kind of strange, but I became a fitness trainer when I was 52. And,
So last year?
Yeah, no. I know, probably about 11 years ago.
Wow.
So I'm very familiar with the body and how it functions. And I also noticed that, a lot of my clients back then, they ended up having rotator tears. And then they tried to just work over it. And I'm like, what are you doing? Why are you doing that? Because my whole sense is it's not going to get any better. It's almost like an Achilles tendon. You have to have surgery on it. There's no other way around it, because if you don't, that muscle can't come down. It's going to atrophy. It's like a rubber band.
I had that surgery too.
Oh, did you? Oh, my
Yes,
gosh.
I did. So, yeah. So,
I haven't had any of those surgeries.
Being an athlete, unfortunately, I've had 5 knee operations, an Achilles repair, my right wrist reconstructed.
Wow.
Yeah, so it's...
And I just have a little pain in my thumb.
I always tell people it's all relative, and everybody's pain is different. So one person's, pain can be, in the eyes of orthopedics, mild, but that can destroy their life.
Yeah.
So you really have to, if it's affecting the person, we take care of it.
Yeah.
The major thing too is don't be too tough. I don't think if you wake up in the morning that you have to see the doctor that day if it was the first time you had pain, unless you fell down the stairs.
Right.
We have patients like that. But I also have the stoic patients that wait 4 months. They have a frozen shoulder. They can't pick their arm up at all. And they say, well, I thought it was going to get better. So it's better to be seen. So if you have a question, don't go on WebMD. I mean, I have patients who come in with 10 pages and say, this is my diagnosis, doctor. 99% of the time they're wrong. Give them 1% they're right, and they've got it in their head that this is what I've got, and my friend Gladys told me this is what I've got because she had it.
Oh, no, because she went to the doctor. She went to school. She learned all about it and everything. Yeah. Absolutely correct. I totally agree. Yeah. Go see your doctor. And please, refresh for our audience here your where they can reach you, your telephone number, website or email, whatever it is, however they can get a hold of you.
Our website is ortho-surgeon.com. Our group is called Orthopedic Surgery Associates, both in Boca and Boynton Beach. We cover everything except pediatric orthopedics. Unfortunately, we're on call 24/7, 365 days a year. We have somebody on call all the time. I actually think I'm on call tonight. But really, we handle everything from the spine, and we also have 2 podiatrists. We have Dr. Kinman, and I just blanked on her name. I apologize. But another excellent podiatrist. So really, we handle everything other than pediatric.
And your telephone number?
Is 561-734-5080.
Excellent, excellent. So if there are any questions that you might have and you can't get to a phone tonight, please, by all means, I hope you have your pen and paper out and you write down that telephone number, because Dr. Shapiro is absolutely ready and willing to help you in whatever manner he can. And not only that, he's got almost everybody in his office. So whether it's your shoulder, your knees, your back, your
If you need a hip or, hopefully you don't, hip or knee replacement. So basically basically I do shoulder replacements. Dr. Grandick and Dr. Wang do hip and knee replacements. Dr. Luskin does basal joint replacements and some wrist replacements. Dr. Kinman does ankle replacements. So basically anything you need, we can replace. You'd rather not have it replaced, but we have the ability to
the
do it.
bionic person, right?
We have patients that when Dr. Zan was still in the group, I did both shoulders, he did both hips and both knees. So we had people with 6 joints, and they were playing tennis and golf and pain-free.
Oh my gosh,
which is nice to see.
Yeah, that is. That's incredible. That's absolutely
Sorry to
amazing.
see, but nice to see.
Yeah, but at least they have somebody that they can go to, and not only that, but somebody that they can trust. And I'm really impressed by your bedside manner, to be honest with you. Anybody who goes in doesn't have a PA, and make sure that you have that communication between the patient and yourself. You're asking questions, and not only that, but you're listening.
What
And
bothers
that's
me,
so important.
Actually, I do have a PA who helps me in surgery, and a lot of my injections he gives once I've talked to the patient. I will see patients, and they went to other physicians, and I'm not trying to knock, I'm certainly not going to give out names.
No.
But they saw the PA 3 times, and they said to the patient, which actually is not legal in this state, and they said, well, when do I see the doctor? And they said, when I indicate you for surgery, you'll see him before you get operated on.
You're kidding.
And I end up
Oh,
seeing
my
them because
goodness.
then they're smart enough. Most of them are smart enough to run, but that's not always the case. So the major thing, if there's any take home here, you want to be seen by the person who's trained to do it. Mm-hmm. One, if the person doesn't examine you, don't go back.
Mm-hmm. Yes,
and
please listen.
have them listen, because a lot of them they look at an X-ray and they tell you what it is. Well, the X-ray may have nothing to do with what you actually have.
Yeah, and not only that, but sometimes you can't see what the problem is just via an X-ray.
A wonderful example is knee pain. Knee pain can come from your knee. It can come from hip arthritis. Okay, and groin pain is hip. Not people always say, and they always reach to their back and say, my hip hurts. So your knee pain can be from the knee, it can be from the hip, or it can be from your back. I have seen people in second opinions for their knee who had scheduled knee surgery the next week from another physician, and I checked their knee out. I wasn't impressed. I range of motion their hip, internally rotated, which is turning, and they scream, they go, oh, my knee. I get a hip x-ray. They have severe arthritis to their hip.
Oh,
their
my
knee
gosh.
is fine, so they would have had a knee arthroscopy for nothing to take care of the arthritic hip. So
wow.
it is out there. So if somebody seems overly aggressive when you see them the first time, because there are some people who just want to get you into the operating room, take 3 steps back, go for a second opinion.
Yes.
And
call Dr. Shapiro.
Again, I saw several people today who live in other states who came to see me, and I said, look, if you want to go back to Chicago, if you want to go back to New York, I know the good guys in all the areas. I just want you to get good care. So my goal is to have people do well. So I also say, go to somebody who's busy, because they're not trying to look for work. They're only doing work what's necessary. So that's sort of a take home as well.
Wow, that's very profound. So I'm so impressed. Thank you so much for coming.
Well, thank you.
Tell us, what do you see coming up in the future? Is there some new technology or something that's on the cutting edge?
Well, they're doing a lot of robotic surgery. So hip and knee replacements, they're doing a lot of it robotic. So people don't realize a robot doesn't do it. You need the doctor guiding the equipment.
Yeah, exactly. It's like a computer,
Yeah, we're not doing it in shoulder surgery yet. The biggest thing that I would say, and I just started to delve in this about 9 months ago, is stem cell.
Oh, okay.
Yeah. So I actually gave 1 stem cell today. I saw a patient who was scheduled for next week. So most of my stem cells are people in the 50 plus with arthritic changes who have failed conservative treatment. Try to give them the cortisone shot. There's something called viscosupplementation, Synvis, Suparts, Orthovis, which is a gel, which helps a lot of people.
Oh, okay, because you that one chewed right over my
so
head.
it's a gel which helps for mild to moderate arthritis. It helps 60% of the population for 6 months to 2 years.
Wow.
But for the ones who really don't want a knee replacement, I am offering them stem cell now, and I've done it 23 times. So far, 22 patients are happy. One person did go for a knee replacement. So it's the next frontier. It's not FDA approved, but it's allowed. There have been no side effects. And I did it on 2 doctors. And because they said, Dr. Shapiro, they actually called me by my first name, but what can I do other than a knee replacement? I said, this is the only alternative. I know I won't hurt you, but I may not help you. And neither of them have had a knee replacement. One's an internist and one's also in an internal medicine type field. They're on their feet all the time, and they're doing extremely well and have never had a knee replacement. So that's the next frontier.
So exciting.
Yeah,
that's
the next
really
frontier.
exciting. Now, the only thing that I think I've heard out there is whether or not it's covered by insurance.
And that's the negative. So basically, if you're on Medicare, which most of the population is, Medicare covers a cortisone shot. Medicare covers physical therapy. Medicare covers the gel shots, the viscosupplementation.
Oh, okay.
Medicare will cover an operation. It does not, unfortunately, cover the stem cell. And there's different ranges of prices. I think some people gouge the population. As I grew up in a little town in Maine, and if you met my father, you'd know why I'm like I am. It's to do good for people, not to do good for oneself. So I charge a minimal amount over what it costs me. Other people triple what it costs.
Oh,
So
goodness.
the charge I do isn't tiny, but it's unfortunately, I don't take it from the pelvis or from the fat. That's one way of getting it. I am getting it from the placenta of pregnant women going in for elective C-section. So everything is tested, their blood, making sure there's no HIV or hepatitis. And the cells in that area, or 1 in 4% of them, are good. If you get it from an 80-year-old fat or an 80-year-old from the bone marrow, it's about 1 in 800,000 cells that are good.
Oh,
so I'd rather be going for 1 for 4 and not sticking a big needle into somebody's pelvis.
Do you end up using the stem cells from the individual themselves?
Well, that's so if you do it from yourself, you're either taking it from the fat or from the pelvis. Unfortunately, the older you get, your cells are not as viable. So I get it from the placenta I personally don't do it. It is done at a tissue bank in Miami.
Gotcha.
And so everything is tested. There's never been an infection. There's never been an adverse effect. I only tell people the negatives are 2. One, it costs money. I mean, I can tell you the price if you want. But, I mean, it cost me almost $2,000 to get it, and I charge $2,500.
Wow.
So I always tell people, if it's going to make you not eat that week, certainly don't do it. Because I can't guarantee it's going to work.
Exactly.
But a lot of people it's helped. So it's just, as I said, it's one extra thing I can add before you have to have a knee replacement. But I also say, look, if you want a final, and the knee replacement is the definitive, I tell people 90 to 93% of the people are happy as can be having a knee replacement. 3 to 4% said, I think I was going to do better. 1 or 2% hate the day they decided for it because they do poorly.
Yeah.
Again, 98% of the people are happy, but unfortunately, 2%, and with so many done out there, it's enough people that are, unhappy.
Yeah.
But, it's all of it is good in its own way.
Yes. Well, I can't thank you again, Dr.
pleasure.
Shapiro, for being here, and thank you, All County Healthcare, for providing and sponsoring this segment. It has
And thank you,
been,
All County, as well.
Yeah, it's been absolutely amazing. Amazing. And now we're going to break for a commercial.
All County Healthcare, Inc. is locally owned and operated, serving the Tri-County area, Palm Beach, Dade, and Broward counties for the last 25 years. The practice of medicine is changing dramatically. All County Healthcare, Inc. still does it the old-fashioned way, where our nurses and healthcare professionals come into your home to service your medical needs, providing you the fastest and best care possible. For more information, call 954-717-7027. And remember, Medicare Home Care is covered by Part A of Medicare with no out-of-pocket cost to you. It's your decision and only your decision on what healthcare agency you use. Call today. All County Home Health Care, Inc. at 954-717-7027. License 200999096.
Hi, I'm Deanna Barron, RN, with All County Healthcare. You know how I know that I've done a good job? We say goodbye. After you understand the medications you take, once you know that gaining 2 pounds in a day means you should call the doctor, when your wound is healed, when you can use your nebulizer all by yourself, when the goals that you and your all-county healthcare team of nurses, therapists, and aides established are met. We say goodbye. Very nice to meet you, and I hope I never see you again. And I mean that in the nicest way possible.
You are listening to You and Your Doctor, Living Longer and Healthier, an informative show that helps you find answers to questions you always wanted to ask, but did not have that somebody that could make a difference in your life. Call into the show if you have a question at 888-565-1470, and we will put you on the air to inform all our listeners. Now, back to our show.
Hi, welcome back. You're here with You and Your Doctor, sponsored by All County Healthcare, presented by AMP2 TV. It's streaming live on amp2.tv, or you can go to allcountyhealthcare.com, and it will be streaming on that as well. So we have our next doctor, Dr. Gannon, who is here to also help us, inform us, educate us on vision.
Oh, it's a pleasure to be here.
It's great to have you.
Thank you.
Thank you for coming. So tell us a little bit about yourself, what your specialty is. We want to hear from you.
Well, I work in the area of low vision, and I started the practice about 38 years ago when I was stationed in the Navy in Norfolk, Virginia, and I was one of the first doctors in the country to be assigned to the office of the flight surgeon aboard a carrier.
Wow.
I was on the Eisenhower.
Wow. Oh, my goodness.
Yeah,
You've got quite a history here.
Sure. When we were in port, I was responsible not only for the flight crew and the pilots, but some of the dependent and retired personnel on the base. And one morning, a gentleman came in his 80s, and he was carrying 2 large bags of magnifiers. And he said, Doc, he said, I've been legally blind for the last 10 years. He said, but last week I went to visit my daughter, and I walked into her home and leaned over and picked a little piece of lint up off of her carpet. And she said, Dad, how did you do that? He said, you're blind. And he said, I don't know. So she said, well, go see the eye doctor. So he came to see me, and he told me the story. And I said, it's very simple. It was light lint on dark carpeting or dark on light. So the contrast was good. It hit a healthy part of your eye so you could see it. And as a result of that, you were able to pick it up. I said, if you walked in looking for it, you never would have found it. And he agreed. And I said, if we could figure out a way to teach you to aim that healthy part of your eye accurately and design a little microscope, you could make ship models again, which is what he loved doing.
Wow.
So he came to visit me every day for about 4 months.
Wow.
And we worked an hour or two a day. Neither one of us knew what we were doing. But by the end of the 4 months, he was aiming that little area pretty accurately. And I designed a small microscope for him. And 2 months later, he was making ship models again.
Isn't that
I loved it.
incredible?
Yeah, so that's kind of how we got started.
That's
was the
quite a
beginning of that.
story, and to be able to get started that way, and you didn't know what you were doing.
Had
or
no
how,
clue. Had no clue. No. Really had no idea.
Oh my
But,
goodness!
Loved it and been doing it ever since. So
Yeah.
it
So,
was a good start.
what is low vision?
Low vision basically means we're dealing with patients who are severely visually impaired. And typically it's from diseases like macular degeneration or glaucoma, diabetic retinopathy, retinitis pigmentosa. All of these things compromise their vision. And when that occurs, at some point, typically in the progression of the condition, it gets to a point where they can't see or function using standard means of correction. Regular glasses and contacts are of no benefit. And at that point, we typically fall into place, and we find those little healthy parts of the retina, as we did with that gentleman in the service. And then we design little telescopes or telemicroscopes and get them to see and function again. So that's basically what it is.
Gotcha. So the whole eyeball is not damaged completely. There are still little areas within the retina that are still healthy that you can tap into and be able to magnify so that they can see.
Exactly. You've got it perfect. That's
Okay.
exactly what we do.
Well,
Yeah,
let me
we
tell
find
you,
those little areas. And,
you were very good at explaining that.
well, thank you. Thank you.
Very interesting. So, how do most doctors perform low vision services, or how many other doctors are in your field? That's what I'd like to know.
Well, there's only a very small handful of us actually that do what I do, and we're members of the International Academy of Low Vision Specialists.
Wow.
And in the country right now, there's about 36 of us.
36?
So not too many around.
Oh, my goodness.
And we're highly specialized in terms of the way that we approach low vision. A lot of the older approaches involve simple magnification. So what they would do would be to start a patient maybe at 2x magnification with a little handheld magnifier and gradually increase the powers until they got to some point where the patient might be able to read or see letters. And at that point, they would prescribe a magnifier or, if not, perhaps a reading machine and try and assist them in reading or functioning in that way. But it doesn't truly get the patient visual in the full sense of the meaning. And also, when they approach it that way, typically they use a lot more magnification than they need in order to get the patient to see. And elevated magnification causes a reduction in the focal range and a reduction in the field of view. So the less magnification you use, the wider the field of view and the more comfortable the focusing range becomes.
Wow, that's
So,
very interesting. Okay.
So that's the typical approach.
Okay.
And what we do is we look for little healthy areas off to the side. And when we find them, we assess them as far as their position and their size and sensitivity. And by doing that, we're able to utilize those areas instead of the dead macula or the dead tissue in the center. And by means of that, we require much less magnification than would be required centrally.
That is
And,
more healthy for the
Sure,
eye.
much better and easier for the patient to function.
Oh, yeah.
So
'cause-
that's the approach we take.
Wow, that's very interesting. So, for our listeners out there, if you have questions for Dr. Gannon, please give us a call, 888-565-1470. We would love to hear from you, and thank you again, all County Healthcare, for providing this information for us, because it's really interesting. So, Doctor, how do they get a hold of you?
If they wanted to call directly to the office, we have
Okay.
a toll-free number, which is 866-942-2020. And they can reach us
2020,
from
I love it.
2020. Yeah, anywhere
How
they want, they can
perfect is
find
that,
us.
huh?
Sure. And we have our main office is in Fort Lauderdale,
Oh,
but
okay.
we have 12 satellite offices around the state. So we're as far north as Port St. Lucie and as far south as Homestead on this coast. And then we're over in Fort Myers and Naples on the west coast as well.
Wow.
So
So how do you manage to get to, I mean, there's only 36 of you. How do you manage to
right.
handle 12 satellites plus
Well,
your main office?
in all honesty, we keep out of trouble. We're very busy this way, which is great.
I would say,
So we move around a
yes.
little bit because the patients can't. You know, they're visually impaired, so they can't see. So it's to their advantage, of course, for us to go into offices close to them. And most of the offices that we visit are retinal surgical offices.
I
so
see.
We're in their offices on days that they're not, and we see their patients in the areas where they practice, and it works very effectively.
Well, that's very interesting, because I was going to say, being the fact that there's only 36 of you and so many satellite offices, and you need wings, my dear.
Well, we're blessed in that we see patients from all over the world, and they fly in frequently. We'll see 2 or 3 patients from overseas almost every month.
Really?
Yes, and in fact, one of my
Wow.
favorite stories, we had seen a patient named Blanche Blackwell, and Blanche was a 98-year-old woman who lived in Nassau, and her aide found me on the internet, and she brought her up in 2011 to see me, and we fit her with a little telemicroscopic system, and we taught her aide how to do the therapy that she was going to require, and she went home and practiced for a couple months, and at the end of that, she called me back in March of 2011, and she said, "Doc, I can read and write and play cards and watch television." She said, "But I've got a girlfriend who's a year older than me that would like to come to see you, but physically she can't. Could you come to see her?" And I said, "Sure." I said, "We'd be glad to." Well, I get a call the next morning from Blanche, and she said, "I've got good news and bad news." She said, "The good news is my girlfriend's going to send you money for tickets to see her, and the bad news is she lives in London." So in May of 2011, May of 2011.
Is that really bad news? I
No,
love
it was great.
London.
I've never been there, so it was great. We went to London. Her girlfriend turned out to be Deborah Cavendish, the Duchess of Devonshire.
Oh, my
And
goodness.
we examined Debbie, and we fit her with a scope. And while we were there, Mrs. Blackwell invited us for lunch at her flat. And she said, "You should have been here last week." She said, "Devo and Liz were here, and we played cards all afternoon." Well, Devo's the Duchess of Devonshire, and Liz is Queen Elizabeth.
Oh, my
and they had been
gosh.
friends for about 65 years. So
That is incredible. I'm getting
neat.
chills. That
It was
is
just
so
a
cool.
neat experience. And for a couple of years after that, when Queen Elizabeth would play cards with her two closest friends, they'd be wearing the little scopes that we designed for her.
Oh,
So
my goodness.
it was a lot of fun. That was one of the
That
neatest
is a great
experiences we had
story.
had.
That is fabulous. So, did you happen to have with you? I'm interested in your treatment and
Well, I
what
brought
you
a
do.
couple of the little scopes with
Did
me.
you?
Sure,
Yeah,
sure.
please,
I'd be happy
please
to share
do.
those with you. The typical one that we use the most often is a little what we call a full diameter telescope, and this is the one that we used with Mrs. Blackwell. And basically, it's a small.
Here's the camera. So
Small telescope mounted on the front of the glasses. It incorporates the patient's prescription. And most often they're monocular because the patients don't progress as far as the condition goes equally in both eyes.
Okay.
So we address the better eye and get it to see as good as we can get it to see, and we try to get the sister eye to relax. And when Mrs. Blackwell would put this on, she would see distance, so she could see across the room and see TV and people's faces much, much better. And then when she wanted to read or write, and she loved to do needlepoint, she'd put the little cap on, and she could go back and do her needlepoint and reading. So
Oh, my
that one
goodness.
device gives her multi-range capabilities. And we had a woman about 3 years ago from Italy who was an international champion at duplicate bridge. And we made a system like this for her. But we split the cap in half and created a bifocal telemicroscope. So she
Oh,
could
my
see across the table
gosh.
through the top and the cards in her hand through the bottom. And once again, she could
was
kind of resume
was
playing cards.
invisible reading through the cards as well?
Well, no, we've been working on that. We
Have you
just
now?
haven't come up with a
Okay.
solution for that one. And I've been trying to find a patient that can see through the occluder on the other eye, too, for all these years. And I haven't run across that patient yet either.
No such luck.
No,
Huh?
no.
Okay.
But, yeah, and then we have another scope that I can show. I'll show you
Yes,
two other
please.
ones, too. This is a bioptic telescope, which is actually a mobility device. It's designed for walking around and actually in many areas for driving. In fact, 43 of the states have approved it for driving and meeting the driver's
Really?
license requirement. And when you put this on and wearing it, the top part has little telescopes, and the bottom part, your regular eyeglass prescription. So you're walking around looking at things normally, and no distortion or blockage of your vision for that purpose, and visual field is full. But when you want to see something in the distance clearer and closer, you simply tip your head down and peek through the telescope, and it magnifies it and brings it into view.
That's so
You might
cool.
want to
Can I-
try that.
yeah,
Sure,
let me
sure.
try that.
Sneak them on for
Ooh.
a second. Bring your chin up a little high first, so you're looking through the distance.
Okay.
And then when you tip your head down, you can look at
It's
a
a new
target out
fashion
there.
statement.
Oh, at least.
Okay, and tip down.
Yes.
Oh my God, that's fabulous.
Yeah.
Oh yeah, like brings her. Oh, I can really see you now, Doc.
Now, we named that particular scope, the frame, a Shelby. And we named it a Shelby because one of our patients was Carol Shelby. If you're familiar with that name from Shelby Cobra or Shelby Mustang cars.
yeah,
well,
sure.
Carol wore those. He had
Wow.
those for 3 years, from 80 to 83, so that he could continue to drive out in California.
That's amazing.
So-
Yeah, it's a new fashion statement. Yes,
Absolutely.
absolutely.
Great for theater. You can see
You know
sports
something?
events. You
You're
can do a lot
absolutely
of
right.
really cool things with
That
those.
is very, very cool because,
So-
many times, especially when I go to the theater, depending on,
The seating, yeah,
the
where you
seating. and I'm like, okay, wait a minute. And I have prescription sunglasses, so I have to put those on. Oh, yeah, I think I can see it now. But these are incredible. It brings you right up. And golf balls, because
Oh, yeah.
I play golf.
Track it, sure.
I can't see them.
Well, you can see the
ball.
hole in the
Yeah.
flag, and sure,
Yeah.
brings all that stuff
Oh,
in
that is
black
so
closer and
very
clear.
cool.
So that's called a bioptic because it sits above the
That
line
is
of sight.
very cool.
And let me share one other one with you
Oh,
too. 'cause
please.
This is a very unique one.
Okay.
Patients with glaucoma and retinitis pigmentosa,
Uh-huh.
in the end stages of those conditions, have tunnel vision. So they've lost all the periphery, and all they see is like looking through a little pinhole centrally.
Okay.
And as they're walking down a hall, for instance, they'd be bumping into things. So what we did here was we created a bioptic position telescope, but we reversed it. And by means of doing that, we essentially take the peripheral field and bring it onto center. So somebody that has a 10-degree field of view is now expanded to 30 degrees. And when they peek through the telescope, they can look down a hall, for instance, and see what's in the hallway and what's in their way.
Let me see this one.
So
Oh,
try
this
that.
is another
It's
beautiful
this
fashion
is
statement,
even a little. Yeah, actually, that's what we
Okay.
call a yeoman frame. It's the ones that we use in the military.
Oh my goodness!
But
Look at
you see, it
that.
brings everything in the periphery kind of onto center.
That is so awesome. That
these
is
are-
fabulous.
Are different avenues of approach.
Yeah.
that we have for
Because
those things.
my mom had glaucoma surgery done, and she was having difficulties. Boy, that is. Now, can you put a prescription on that as well?
Yeah. We
Okay.
put the prescription in the
Okay.
carrier, which is the base lens, and
Baseline.
in the telemicroscope.
And then you can
Sure.
have the bifocals down below.
Below if we need to. Sure.
Okay.
Sure, we can add
Wow.
bifocals. We can even put progressive ad lenses in there if we need.
Really?
Yeah, we can do a lot of
Can
unique
I get
things
it
with
in red?
them. Red actually is one of the colors.
Is it?
Yeah,
Okay,
that
okay,
particular frame
cool.
comes in red, pink, blue, and silver, as well as the
I
black.
like that.
Yes, yes.
Blue's my favorite color, but I like red too.
Well, the company that makes these, if you ever see those posters of surgeons in the operating room, and there's like 3 or 4 of them standing around, and they're
Yes.
wearing these black frames with the little microscopes. Those are
Yes.
them. That's actually the frame.
Really?
Yeah,
Is
yeoman
it?
frame is the
Okay.
most common
Yeah, I have
that
one of my girlfriends. She's
used
a
for that.
plastic surgeon.
And she, yeah.
And she was doing a little something on my leg. I ended up having a little boating accident, so she had to put a couple stitches. And all of a sudden, she's turned around. She says, "Excuse me while I'm doing my fashion statement."
Mm-hmm.
And she puts on these great big glasses, and I looked at her like, "Oh my God, really?" She says, "Oh yes, I really turn on a lot of guys with these
with
things
these glasses on.
Yeah. She says, "I know how to scare them away."
So those are just some. We have over 5,000 different designs.
Really?
Optically. And then, of course, we have all of the typical handheld magnifiers and things that we would utilize in the more common sense of low vision correction. But
So, what are some of the other therapists or groups of therapists that you might want to tap into? I mean, is it like occupational therapists?
Well, occupational therapists. When I came back from the service, I trained a technician to do what I had done up to that point with the exercises and the therapy. And then several years later, in 1993, we brought in an OT and we trained her in the things that we had done. And we incorporated some of the OT methodology as well into the program. So now what used to take us 6 months, we could do in 6 weeks, which is wonderful from that standpoint.
Oh my gosh, that is incredible.
Much more effective.
Yes.
And but most of the occupational therapy groups that do OT and low vision do more what we call adaptive compensatory strategies. And what that means is if somebody couldn't see, for instance, to cook in the kitchen, they would mark the stove with 2 bump dots. And when the patient turned the dial, they would feel the dots coming together, and they would be able to sense that the stove was on, and it was set for 350 degrees if that's where the dots met. Well, what they've done is they've compensated for a loss of vision and adapted to it and compensated with the sensory modality of touch. So there's no vision involved in that rehabilitation. It's more or less a low vision survival skill that involves touch instead of sight.
Right.
What we would do would be to teach the patient to use the healthy tissue to the side of center, and then they'd put a telemicroscope on, and by looking directly at the dial, they'd see it and they'd set the temperature because they'd be visual.
Yeah,
so it's a
and let me tell
restorative
you,
process,
that's probably the better.
Which is the way to go.
Yeah, absolutely, because you want to be able to see it, especially if there's a flame. You want to be able to see how high that flame is. I just want to, say thank you so much, All County Healthcare, for sponsoring this segment as well. Dr. Gannon, you have just been a realm of information here. If you do have any questions, please give us a call. We would love to answer any kind of questions that you have. 888-565-1470. Give us a call, and we want to inform you. We want you to be able to have all the choices that are available to you, especially this particular expertise that we have here, the specialty, and being able to have somebody who knows how to correct the vision. Because how many people are really going through life pretty much blind?
Huge. In the Tri-County area down here, there are 180,000 people between Dade, Broward, and Palm Beach counties who have compromised vision as a result of these conditions.
Oh,
Yeah.
my gosh.
Huge.
So please tell the audience how they can get a hold of you again, where your office is located.
We're as far north as Port St. Lucie and as far south as Homestead. We're on the West Coast in Fort Myers and Naples. And the best number to reach us at would be 866-942-2020.
Excellent. So, if you can't give us a call tonight, please, I hope you've marked down that telephone number so that you can speak to Dr. Gannon or one of his colleagues in order to help you get the proper and correct vision so that you can, have quality of life. That's one of my, major sayings. If you have quality of life, you have quantity of life. And anything that we can do to be able to help you make the right choices and also find the right help in order for you to have that quality, that's why we're here on air. So that's very, very exciting. What else do you want to share with us? Maybe about the macular degeneration? Is there?
Sure. We could talk a little bit about that.
Excellent. Yes, please.
For many years, the only treatment that we had for macular degeneration, especially wet macular degeneration, was a laser procedure. And when we used a laser to stop leakage in the back of the eye, it's sacrificial. We destroy tissue in order to preserve the remaining tissue. So the patient would go in thinking, oh, I'm going to have this laser procedure and my vision's going to get better. And typically it didn't. It would get a little worse, but it would preserve the rest of the retina and hopefully stabilize or, cause the progression to be diminished as far as the progression went from that point forward.
Gotcha.
And through time, we've gotten much better. We now have injectables that we use, Lucentis and Avastin and Eylea, and these drugs are able to stop the leakage, but without any tissue damage.
Wow.
So now we have ways to kind of control the situation and stabilize it that are far more effective. These were some of the greatest godsends, if you will, as far as treating this condition that we've had in the last 30 or 40 years, and they're available to us now. And in the future, just as you were speaking about stem cells before, we're going to have some great stem cell solutions, I think, for replacing the cells in the macula that have deteriorated. So we should have ways to kind of reverse the condition.
Oh, my God. We're going to be living to 150
well,
pretty soon.
we're going there, and with a good quality of life all the way along, which
yes.
is, as you said, that's the important part. If you've got the quality, it just makes it so much more effective.
So are these particular glasses, are they covered by insurance?
Actually, the examination is covered by most insurances and Medicare and Medicaid.
Okay.
The therapy is also covered by most of those entities as well. The glasses are not. So like hearing aids or dentures, unfortunately, they don't cover the cost of the glasses.
Oh, okay.
And low vision devices may be from a few $100 to a couple $1,000s. So they're not necessarily inexpensive, but they're not way out of base. Hearing aids frequently cost a lot more than some of the low vision macular degeneration type devices.
Gotcha.
Sure.
Okay. So, but that's good information, though, because if you can't see, sometimes the most important thing is your sight and be able to have that level of life. And be able to do the things that you used to do. I would imagine that this has brought back some golfing for some people.
Oh, sure. Golfing, driving, working with their hands.
Yeah.
I've got people that have done artwork for us. We have some beautiful woodworking pieces in the office.
Really?
And some paintings that patients have done through the years. And I've the lady that had these did a beautiful needlepoint for us. So we have that in the office. Yeah, a lot of kind of unique little things that way.
That is absolutely amazing. Tell me about the treatment, because you did mention treatment. So what does the treatment look like?
You mean from the standpoint of medical treatments for that, the injections and those things?
Yes.
Yeah, the treatment would actually be an injection in the eye of the Eylea or the Avastin and the Lucentis, which sounds terrible. And one of the things that's kind of unique about this, a lot of times, is many of the doctors who are doing these treatments don't follow through suggesting or recommending that the patients actually have a low vision service beyond that. And from the standpoint of an analogy, it'd be like an orthopedic surgeon removing your leg. And after he does that, he said, well, my job is done. Everything's healed up and have a nice day.
See you later.
Yeah. As compared to maybe saying, go see somebody and see if you can have a prosthetic limb and walk again or crutches or if you're stuck in a wheelchair.
You got to finish the job.
In a wheelchair. I mean, So that continuum of care is critical.
Okay.
And we need to establish that, especially among those doctors who are taking care of patients with macular degeneration and other degenerative conditions, so that they understand that when the patient says, Doc, I can't see, I can't read, what can be done? Instead of saying there's nothing else that can be done, they really need to say, hey, why don't you go and see if there's a low vision doctor someplace and see if there's any assistance that might be available to you to see better. And of course, if we can't do it visually, then we have to utilize a service where the patient may get orientation and mobility training and work in a blind world. But it's a shame to have somebody working in a blind world that could otherwise be seeing.
Absolutely.
So it's so important for them to find a doctor who's very well versed at all aspects of this and can find that healthy tissue that the patient has and assess their function to take the greatest advantage of their remaining vision.
Yeah, well, I had one of my dear friends is the executive director for the Lighthouse of Broward, and her and I had worked together for quite some time. But her whole passion was in helping the blind person be able to function properly within their lifestyle.
Sure.
You know, be able to find transportation, be able to get the proper care that they needed, be able to be self-sufficient. So, I mean, all of that is absolutely essential in an individual feeling independent. And I believe that that's really what a lot of the elderly are looking at. They still want that sense of independence and still be able to live their life and maintain that lifestyle.
Sure, and safety and everything else. These are all very, very critical. And we refer patients regularly to the Lighthouse.
Do you?
Yes, especially if they're beyond visual rehabilitation. So if we can't do something with them visually, then those adaptive compensatory type skills become very important. And the Lighthouse does a wonderful job
They do.
in acclimating patients and teaching them those things. So it's a good resource from that standpoint.
Yes, yes. Well, that's great to hear. Anything else you'd like to leave us with?
Boy, the most important thing is, again, if you know somebody that's struggling with visual impairment, if they've heard that there's nothing that can be done, please have encourage them at all costs to try to go to see somebody.
Yeah, well,
that
you
can
said
give
that you
them
had a
some assistance
website. Why
that way.
don't I mean, I hate to interrupt you, but how
No.
about if you turn around and give the website?
Okay,
because
the
that
website
way,
would be the lowvisioninstitute.com. And you can find us that way. And again, the phone number was the 866-942-2020, and that'll get you directly in touch with the office as well.
Excellent.
So, and we're always happy to answer questions.
I'm telling you, I'm so excited to have you on here. Thank you so much for taking the time out to spend with us, help educate us, allow us to know what is available for vision. And again, you know, please, by all means, give Dr. Gannon a call and let him know. So I thank you very much. Thanks for being part of our show tonight. We're on every Tuesday evening from 6 to 7. You and your doctor. I'm Lorena Anderson, your life and energy coach, and I'm thrilled to continue to bring you these great quality doctors to inform you and have you make the best choices for your health. Good night now.
Thank you for letting us share with you a longer and healthier lifestyle. If you have a doctor or are a doctor and wish to be on the show, call AMP2 TV at 866-244-5422, and we will put you on the air as soon as possible. Tune in next week for more information on living longer and having a healthier life.
The opinions expressed on the preceding sponsored program were strictly those of its hosts, guests, and